My name is Adelina Comas-Herrera, and I'm delighted to welcome you to this webinar. This is part of a wider series of webinars in the Global Observatory of Long-Term Care. So I'll tell you a little bit about the observatory, and then I'll hand over to Elena Moore, who's convening this interest group on care and social protection in Southern Africa, and then we'll hear from the speakers. And some of you may have seen this before, but for some of you may be new. So with this platform we're using today is called the Global Observatory of Long-Term Care. And this comes from a collaboration that happened during the COVID pandemic, where many academics got together to try and share information and data about what was happening in terms of during the pandemic for people who were relying on care from others. And the situation was very different in different countries. The challenges, we all heard about it, but we know how much the pandemic affected particularly older people, and those who needed care from others, by definition, had to be in contact with other people who were at higher risk of contagion. And we heard a lot about care homes, but we also understood how important it was, the impact on people who live in the community and rely on care, and how much the pandemic seemed to ignore them. So the idea was that we needed to learn from this experience. So we created this new platform called the Global Observatory of Long-Term Care, with the idea that it supports cross-national learning to improve and strengthen care systems. It's part of an international long-term care policy network that was already existing, focused on international long-term care policy. And here what we want to do is we want to use different activities like these webinars to identify key shared challenges and showcase how different countries and localities are addressing them, share research evidence, facilitate collaborations, and everyone is welcome. We expect to be this platform to be of interest for policymakers, industry advocates, care professionals, and of course, many academics are members and contributing. If you'd like to join the observatory, it's free to do so. You can register as an expert by completing the form in the link, and we will also share that in the chat. And the idea here is that basically you share your knowledge, you find others with similar interests. We are organized around interest groups, which helps facilitate that, but you can also share your publications. You can also let us know about events. We can help publicize, and we have a monthly newsletter at the moment that also can share your news. We have the next webinar planned next week, in case that's of interest, on the 11th of April. And this will look particularly at understanding and reducing dementia stigma. We'll be looking at across cultures to understand things globally, but we will also be looking at two interventions, one in Brazil and one in Kenya, aiming to reduce dementia stigma. And also we'll be hearing about the global survey on attitudes to dementia. And I wanted to also mention that all the webinars are recorded, so this will be recorded too, and you can find the videos on the videos section of the website. And I'll just let you know that we also have a conference. This is in Spain this year in Bilbao from the International Long-Term Care Policy Network, where some of you will also be sharing your work. And with that, I'm going to hand over to Elena Moore, who's going to tell us more about the care and social protection interest group in Southern Africa. All yours, Elena.
Thanks, Adelina, and welcome everybody, and good afternoon for some and good morning for others. I'm Elena Moore. I'm a professor at the Department of Sociology in University of Cape Town. And together with my colleagues, we decided to start up this interest group on the care and social protection of older persons in Southern Africa, which I suppose, similar to many other interest groups, is bringing together researchers, academics, and policymakers, government officials, practitioners who are working towards, a better understanding of the impact of social protection on the care needs of older persons within a particular context, in this region. And really where this work comes from, so myself, my colleagues are, some of whom are here today. I see Professor Janet Anane, she's here. And I think I know maybe half the people in the room here. I look forward to getting to know the other half. But where this came from really is the last couple of years we've been developing a care of older persons network. It's called COPSAN, where Similarly, policymakers, researchers, government officials, and NPO, and civil society advocates and others have been getting together and working through a series of questions and issues and sharing knowledge and kind of experiences in thinking around care of older persons, particularly in the region. And out of that network grew a particular program called the Family Caregiving of Older Persons program, that again, myself and Dr. Ananade from Namibia, Professor Nsane in Botswana, Dr. Gwen Lesitedi in Botswana, and Dr. Jasmine Chinsanya in Malawi are working together with a team of about 40 researchers across 4 countries, thinking about family caregiving of older persons. One of the key parts of the long-term care activities that often gets, that's surprisingly very little understanding on that area, given it the fact that it's the most dominant form of long-term care in the region. So that's where what we've been doing. I think we've just popped our website into the chat box. It's familycaregiving.org.za. And so we're busy in a multi-site, multi-country kind of study, but also doing quite a lot of policy work alongside that, in mapping the funding of elder care and the long-term policies that do exist in the region. So that's who I and we are. And so the interest group was a great opportunity to connect with others across the continent, but also across the world, needless to say, who are doing probably similar stuff elsewhere. And so we could share our experiences and hear from others about theirs. So today we're starting off with 2 very eminent scholars in the field of social protection more broadly and long-term care specifically. So our colleagues and guest speakers probably need no introduction whatsoever, but I will nonetheless take this chance to welcome both Professor Peter Lloyd Sherlock and Professor Armando Barrientos. Now, I'm not sure if Peter Sherlock is here yet, Lloyd Sherlock is here yet, but we'll come to that. So if I may, Emeritus Professor Armando Barrientos is a Professor Emeritus of Poverty and Social Justice at the Global Development Institute at the University of Manchester in the UK. His research interests focus on the linkages existing between welfare programs and labour markets in developing countries, and on policies addressing poverty, vulnerability, income security, and population ageing. So thank you, Armando, for joining us today and for sharing, sharing all your expertise and knowledge. I'm not sure if Peter has joined us yet, Adelina.
I haven't seen him yet, and I haven't looked back, but
okay. I mean, I'll introduce him nonetheless, so that if he does join, and we hope he does, that he can then launch into his presentation. So again, I presume it's most people know Peter Lloyd Sherlock fairly well. He's been a professor of global health and gerontology at Northumbria University since 2023. But before that, he held posts in different parts of the UK. His research focuses on social protection, health, social care of older adults in low and middle income countries. He's wrote, incredible vast amounts about long-term policy in the region, but also about links between research and policy, which are, excellent references, was particularly when one is engaging in such work. So what I'll do is I'll hand over to Professor Barrientos.
Thank you very much for the invitation to speak to the seminar. My presentation is going to be on income security for all the people in Southern Africa and Latin America. I kind of pared it down because I thought I had a short time, but I guess we'll have more time to discuss some of the issues that it raises. I'm going to concentrate on 3 points. The first one is something that I think is important to all of us, that aging is not necessarily associated with a decline in well-being. The perception, I think, in terms of policymakers and politicians in most countries is that there is a decline in well-being which is associated with the process of aging. And I hope to make the point that that doesn't necessarily have to be the case, that public policy is capable of making that, reverting that process, reverting those pressures. And the kind of public policy that is effective includes both old age transfers in the kind of different designations, social pensions, non-contributory pensions, occupational pensions, and so on. And also kind of services that support households with older people. So those are crucial in making, in reverting this potential decline in well-being. And then I'm going to try to make a point which relates to both Southern Africa and Latin America, which is to do with the fact that if you look at Latin America, where there is a mix of different sources of income support, there is public transfers, old age transfers, there's occupational pensions and savings instruments. They can be helpful to some people, but they generate considerable inequality. And one of the points that I learned from South Africa and Southern Africa is that starting from a very strong public support for income support in old age is essential really to reducing inequalities in old age. So those are 3 points I want to make. The basis of the discussion is going to be from a research project which was done in 2002 and 2008. It was entitled Aging, Wellbeing and Development, a comparative study of Brazil and South Africa. The team that did this research consisted of Valerie Moller from Rhodes University, Professor Joao Saboia from the Federal University of Rio, Peter Loichelloc, and myself. We are fortunate to have research funding to collect a sample of data from households with older people in South Africa and Brazil. The requisite for people to come into the sample were that they had to have a member in the household of at least 55 years and older. And there were 2 instruments that we used. One was for the household and one for each older person in the household. That was done separately. So that was kind of the structure of the data. It is these surveys were not representative of the 2 countries. In fact, we only collected data from an urban area and a rural area. In the case of South Africa, it was from Cape Town and from the Eastern Cape. And you can see there the number of households we collected data from 2002 to 2008. There was attrition that was significant in both countries, about 35% in the context of South Africa. We use kind of replacements to replenish that sample. So that is a kind of empirical basis. Now, let me tell you that you will find much more up-to-date studies on South Africa and Brazil, which probably give you much detail and up-to-date information on all the households in the 2 countries. But I'm going to focus on this because of the kind of methodological aspects of it that might be helpful to the kind of work that you're doing. One concern that we had was that, I mean, it was fairly straightforward to do, for example, a comparison of the 2 countries to look at poverty in the households and to focus on income or focus on expenditure for the 2 countries. That was fairly straightforward to do, and I dropped that because I thought, you know, there would be more up-to-date information on that. But one kind of particular issue that we were interested in considering is the extent of deprivations in the household that went beyond income, and particularly in terms of the in terms of the older persons within those households. So we try to develop a measure of the kind of deprivation that were present in these households. And so what we did was to collect information on a number of well-being indicators that you can see from there, from the slide. So, for example, we considered the issue of health. We looked at self-reported health, life satisfaction, safety, social participation, financial control, the extent of debt in those households, the presence of durables, the access to water, and expenditure. I forgot to mention that probably it was obvious that the kind of households we're interested in were households in low-income settlements, right? So the idea was to generate some kind of instrument that would allow us to look at the deprivations in these households. So we set a deprivation threshold for each of the dimensions. For example, if you look at the expenditure at the bottom, those households with the bottom two deciles for expenditure were considered to be suffering from deprivation. In terms of life satisfaction, households where all the people reported that were very dissatisfied were considered to have deprivations. So that the first stage was identify well-being dimensions. For each dimension, define a deprivation threshold, and then aggregate those for each household. There are kind of some complications that I'm sure most of you are aware with, but I'll kind of highlight. For dealing with multidimensional deprivation issues. The first one is that, of course, not each dimension counts for the same for the households concerned. It may be that they have, particular preferences for some as opposed to others. But of course, we couldn't go into the preferences of households to inform that. So basically, each dimension counts the same. The second, that this implies that dimensions can be substituted, so that, for example, better life satisfaction and can go together with deprivation in terms of expenditure or in terms of access to water. The other kind of assumption is that the more the deprivations that are suffered by the households, then the poorer they are. Those are kind of issues that need to be discussed in more detail in the context of developing a particular instrument. Now, this is what we came up with in the context of the panel in South Africa. I actually, because of the time, I dropped the Brazilian one, so I apologize for that. Now, so if you add the households and you consider their deprivations, then what you get is something like the picture on the left-hand side. It's entitled Multidimensional Deprivations for the South Africa Panel, 2002-2008. The bars that you can see measure the proportion of the population and the number of deprivations. So, for example, there are 38.99% of the sample that have 5 or more deprivations in the South Africa panel. If you look at 2 or more deprivations, 80.65% of the sample have 2 or more deprivations, according to the information we had. So that you can organize kind of households according to the number of deprivations they had. Now, if you compare that with the panel that we collected in 2008, then you can see that deprivations have been reduced. For example, for 4 deprivations, 50% of the sample in 2002 had 4 or more deprivations. By 2008, that had declined to 1/2. 25% of them had 4 or more deprivations. Now, those are the numbers, but if you look on the right-hand side, that is a simplified version of it. We just drew a line connecting all these bars. So basically, what you can see from this graphically is that from 2002 to 2008, the number of deprivations declined for the households because the red line is to the right and further down to south compared to the one in 2002. So we could say then that in all the households in these areas in our panel had improved their multi-dimensional deprivation in the 2 periods. I put on the kind of a description of the talk. I put the paper that was published, but you can find this information in this working paper, which is more easily accessible, I guess. Right. So, what about the impact of public policy? Here we're going to divide the sample between those in the sample that had access to a pension, a social pension, or non-contributory pension, and those that didn't. Now, in the context of South Africa, you have to have some lower level of assets and income to be able to access pensions. So non-pensioners are necessarily better off than pensioners. You can see in the figure there that if we look at 2002, the non-pensioners were the broken black line, and the pensioners were the straight black line, the kind of consistent black line. So effectively, the non-pensioners have much lower level of deprivation count than the non-pensioners, right? Which is explained there. Now, if you then do the same for 2008, those are the green solid line and the green broken line. The green solid line are the non-pensioners, are the pensioners in 2008, and the broken line are the non-pensioners in 2008. And you can see that the count of deprivations for the households in the sample have declined between 2002 and 2008. Okay, so that was my first point. Basically, aging doesn't necessarily have to be associated with a decline in well-being in all the households. As you can see, 6 years later, households in our sample in South Africa were better off in terms of the number of the deprivations that we could count. The second point is that, of course, access to pensions and access to better services is what explained why these households were better off 6 years later. So public policy does have the capacity to break the link between aging and well-being, if there is one in the first place. Right, so there are other complications that we need to take in mind for those that come from South Africa, of course, at the same time as the presence of social pensions and improvements in basic service provision. There was the child support grant that was expanded around the time that could also have an impact on these on kind of multi-age households. If there are children in the households, then households would have had access not just to the social pension, but would have had access to the child support grant. Okay, so those were the 2 points. The third point that I wanted to discuss was in the context of South Africa, you start from a situation where the income support for the majority of the population comes from social pensions, which is a public transfer, out of government revenue. Now, what about the example of countries that have a different way of organizing income support in old age? Latin American countries have 3 ways in which income support in old age can be organized. There is occupational transfers, which are the traditional way in which social protection has been organized in the region. That involves workers and employers making contributions to a fund that is then used to support and finance pensions in old age, occupational pensions, right? There is also the capacity of households to save. In 10 countries in Latin America, they have introduced individual retirement saving accounts, which are similar to the IRS in the United States. That was because in the neoliberal period in Latin America, governments were really concerned about fiscal deficits. So basically, they pushed pensions to the individual. So it's just based on individual savings. In some cases, employees also contribute to that. So under individual savings, you're mandated to save some of your salary in a retirement account, and that you can use to make pension arrangements when you reach retirement age. And the third one, which is social pensions or non-contributory pensions, which are old age transfers rather than pensions themselves, began to be introduced in all countries in Latin America from about 2000 onwards, right? So you have historically, initially occupational pensions, then between 1980 and 90, some of them were replaced by individual retirement accounts. And then in 2000, you have an extension of non-contributory pensions or tax finance pensions. And what you get is something that is highly unequal, as I'm going to show you here. I did this work for a book that is just about to come out, which is called Social Protection in Latin America, with household data from 2012. And I organized, I considered all the income from social pensions, occupational pensions, and individual retirement accounts that people age 65 and over get. And I divide them into centiles, and then I put them from poorer to richer in terms of the income support, and that is what you get. It's basically a kind of hockey stick, right? You have nothing or very low pension provision, and then when you get to about the 85th centile, you get a very rapid rise in the pension income that people get.
Prof, I'm just going to interrupt you for a second, just to say another 2 minutes. Peter has joined us.
Right, okay.
You may not have been aware. Yeah, sorry, apologies. I know you probably can't see the chat. So
okay.
Just 2 more minutes would be great. Thank you.
That'll be fine. That'll be fine. I'm coming to the end. Right, so you can see a kind of hockey stick in some countries like Brazil or Bolivia, for example. Most of the, if we take a country like Brazil, for example, the bottom 20% of people aged 65 and over have no income support whatsoever. Then you have something around 50% of people age 65 and over that have just a minimum basic level of income support. And then you have, on the right-hand side, pensions that get very, very high pensions. These are parliamentarian, judges, members of the armed forces, and so on and so forth. As you can see from all the countries in Latin America, just visually, this kind of hockey stick reveals very large inequalities in terms of income support. Now, going back to South Africa, South Africa started from a different point. They started by building public old age transfers for people, right? The old age grant. And that has really been successful in terms of reducing poverty and vulnerability on all the households. If you look at Latin America, on the other hand, they started the other way around. They started from people who are better off for employment, and then they are moving kind of towards the South African model by expanding social pension in most of the countries. So you need to take into account in considering income support that where you have a mix of individual, occupational, and private pensions, you also get very high levels of inequality. And the last point that I want to make is, or I want to tell you about, is that I have a social assistant explorer, which is at that address. And you can actually get information on all countries on social assistance provision going up to 2015. I'll stop there. Thank you very much.
Thanks very much, Prof. And that is fantastic presentation. And also I reread your chapter that you had shared. And I think Adelina just mentioned that all the readings are available on the website. So thanks for sharing those. I'm going to move on to introduce, I've already introduced Peter Lloyd-Sherlock. Thanks for joining us. I'm delighted you're here. You have 15 minutes or so, and then we'll open up to questions from the floor.
And while I'm just putting my slides up, I just want to emphasize something that I am very much a big fan of social pensions. I think they have been a major policy plank, social policy plank in South Africa for reducing poverty in poorer households containing older people and people with disabilities. However, I'm going to argue, I also think that they are a fundamental part of what you might consider the post-apartheid social contract in South Africa. And so I defend them wholeheartedly. However, I am going to argue that I have some concerns about the view that old age grants, whatever you call them, my view is that they cannot be seen as a key policy for the health and care needs of poor older South Africans, just as they can't be a key policy for, I don't know, addressing youth poverty or unemployment in South Africa. They may have some indirect effects on all of these different things, but I don't think they can be the central plank of these policies. And that's why I assume you can see my overheads. I refer to, can pensions do it on their own? And the answer is, as far as I'm concerned, that they can't. I'm going to scurry through some analysis. All of this is published analysis, and so I'm going to list various papers at the end. So I'll probably go through it quite quickly because I want to kind of get to my key take-home points at the end of the conversation. So can everybody hear me clearly and see the slides? Great.
Yes.
Okay. So first thing is, two of the leading causes, they're not necessarily the two most important, but they are very important, of illness, avoidable mortality, and disability, and therefore care dependency for older people in South Africa are things like cardiovascular disease and stroke, which are very strongly affected by high blood pressure, obesity, smoking, and other modifiable risk factors. And so in a way, if we want to look at the effects of pension, it's quite useful to focus on these particular things. Over the years, working with Armando and subsequently in a number of other studies, I've tried to look at these effects, comparing outcomes among older people receiving the old age grant and similar individuals who are not receiving the old age grant, and really wanting to be able to find a positive association. But sometimes, no matter how much you want to find an effect, the effect just doesn't seem to be there in the statistics. So in a number of analyses that we carried out now about 10 years ago, we found that there was no effect of receiving a pension on older people being more likely to be either not having high blood pressure, or if they had it, to be effectively managing it through effective medication or other behavioral change. So you were just as likely to have hypertension, and you were therefore just as likely to have the consequences of hypertension, such as acute cardiovascular disease. And we found that among pensioners, just to give you a flavour of this, only about 1 in 8 who had hypertension, and the majority of them did, had been able to control their condition. And that, in fact, as far as the statistics show, South Africa, among its older population, had the highest rate of uncontrolled hypertension in human history, and incredibly high rates of incidence of stroke and other kinds of cardiovascular disease. So this is in the context of a country that's done tremendously well to provide cash transfers to poor families containing older people, but we can see that if we want to start looking for specific health effects that are very important to us, these do not seem to be making much of a difference. Partly as a result of that, working with colleagues up in Bushbuckridge from Witwatersrand University, we thought, well, what can we do about that? And we did develop a small intervention study, which we piloted and we showed to be valid, where we worked very closely with older people who were queuing for their monthly pension at pension pay points in villages in Bushbuckridge. And we provided them with screening for blood pressure, and we also offered them low sodium salt as a potential intervention to enhance their ability to lower their blood pressure, and also advice about attending health centres. This was very effective, actually. It was very popular. Unfortunately, we weren't able to get funding from this, partly because we were unable to persuade SASSA, the South African Social Security Agency, to work closely with the Department of Health. And clearly, these sorts of intersectoral collaborative challenges are another barrier, perhaps, in terms of taking cash transfers and converting them into something which could be much more specifically useful for improving health and care outcomes. South Africa, and these are data from 2014, has a very, very high rate of people who are overweight and obese. So this is for people aged over 50, originally WHO data. And if you look at the green line for South Africa, you can see that it varies from about 65 to about, what is that, about 85%. Q1 are the poorest 20%, Q5 are the wealthiest 20%. What we can see here, that regardless of whether you're relatively poor or relatively rich, the large majority of South Africans had problems of being overweight or obese, which added to their hypertension puts them at tremendous risk of premature mortality and health episodes which will increase their levels of care dependency. So there's been a lot, and I think it's rather dated research, looking at a very different context, perhaps 20 years previously in South Africa, where food insecurity and undernutrition were really quite prevalent, particularly among poorer African families. But that simply isn't the case these days. And where you, so the arguments in the past that pensions are used to enhance calorific consumption of older people and their family members, I think that those are quite relevant 20 years ago, but much less relevant now. So this is simply a breakdown, again, from Agincourt, using data from 2015, of how pension old age grant money was being spent by households. And this is self-reported. So according to what people said when they were asked, nearly half of that was spent on tobacco and alcohol. I suspect, in the experience of other studies, consumption spending on things like tobacco and alcohol is always extremely underreported. People tend to play down the amounts of money that they spend on those sorts of things. Now, again, you might say, well, perhaps what we need to do is provide some kind of dietary advice and health promotion messaging to these older people so that they could use the money they're getting from their pension and they could spend it on things which are perhaps better for their health and better for the health of family members. And of course, theoretically, that could be done. In the case of South Africa, partly in a context of a very little engagement between older people, particularly in rural areas, such as the area we were working in, and primary healthcare providers, and also in a context in which primary healthcare isn't very interested in providing public health messages to older people, where we looked at whether the people in our survey had been even just given advice about stopping smoking, changing their diet, managing their weight. We found hardly any of them had, whether they were in a pension household or a non-pension household. So I am quite concerned that there is a discourse out there which is very supportive of social pensions, old age grants in South Africa. And partly because of that, is desperately striving to demonstrate the wider beneficial effects they have on older people and possibly on family members. These are just 3 studies that came out in the last 3 years, all of which are claiming a very strong effect of social pensions on older people. But in fact, when you look at the analysis, you find those effects are extremely marginal and questionable. And often what you see in these studies is they look at about 30 different health outcomes, and they found one which has a marginally significant effect, and that becomes the centerpiece of their the paper that they publish. This is a slightly more nuanced way of portraying the issue, and I was involved in this study with HelpAge International and HelpAge, not just looking at South Africa, but in this case looking at a number of other countries in sub-Saharan Africa. And again, we show that cash transfers can have a positive effect and can improve health, but we also emphasize that they can't do this on their own. There needs to be a strong policy addressing specific health needs, including health promotion for older people. And if your infrastructure of health and also social care services is very weak in a country, be it South Africa or anywhere else, the capacity of cash transfers to improve outcomes is extremely limited. And this leads me on quite quickly to, I guess, a debate which is much more central to this group's interests. And this is a debate I'm engaging very much with in Brazil and in Thailand and a number of other countries, where increasingly, as people are becoming concerned about meeting the care needs of older people, particularly poor older people, the policy of choice appears again to be cash transfers of one kind or another. Now, to some extent, and Armando and I have been working on this in the past, there is some evidence, often rather indirect evidence, that if an older person receives a pension and they're living with other family members, those family members, perhaps for reasons of self-interest, as opposed to altruism, are more likely to try and invest in the well-being of that older person. And certainly there is evidence that pensions bring together households, that if an older person has a pension, they're more likely to have younger family members living with them. And there's been a lot of evidence that pensions are shared across households. Where this again goes into slightly difficult territory, and it does sound like I'm an enemy of the old age grant and social pensions, and I'm not, is trying to understand the actual experience of these older people and their families, and trying to establish whether pension sharing is something which older people are happy to do, or whether this is actually quite coercive. And when you start looking at this quite difficult issue, a small piece of research I was involved in again a few years ago found indications that pension sharing was often, firstly, an issue which would be looked at very differently by older people and by younger family members, and that there were quite high rates of financial abuse of older people. And those of you who are familiar with the literature on financial abuse know that an older person who has high levels of care dependency and functional impairment, who's living in a context of poverty, is much more likely to be exposed to what people might define, although it's difficult to define, as financial abuse in these contexts. So one issue I have is that if we're talking about providing more money to households who are experiencing poverty and where older people are highly vulnerable in terms of other family members helping them and because of their functional limitations, this may not achieve the purpose of improving care outcomes for those older people. There is one country, loosely speaking, in sub-Saharan Africa, which does have a large program of cash transfers to try and address the care needs of older people. And that's the Seychelles, who've been running a home care program for about 20 years. And basically what that does is provides a cash benefit to families, which can be used to pay either a family member for their unpaid care or somebody else who can be paid provide care services to older people. There have been a number of evaluations of that intervention, and it's been shown to be really quite ineffective in terms of actually improving care for older people in the Seychelles. There have been massive issues in terms of targeting this intervention. How do you decide who is sufficiently care dependent? How do you decide who takes decisions about how who is receiving the care grant? Is it the older person or is it a family member? There have been concerns about cost escalation, and there's no mechanism in place, or there wasn't until 18 months ago, to actually oversee, supervise, assess, quality assure what's going on in these households to see if it's actually having any effect on improving outcomes of older people. Very, very, very little uptake of training or educational interventions that the government has tried to provide among family members receiving these grants, which is, again, of course, for concern. So just wrapping up, from my point of view, and this is very much my own personal experience, although it's interesting that I think these recommendations dovetail quite nicely with Human Rights Watch, their very good report that came out about social care in South Africa last year. I think if we want to start identifying, and of course there are many things we need to do, but specific priorities for long-term care in South Africa, I would say there are two things that we need to start with. One is trying to improve cooperation between the two lead agencies, which are of course the Department of Health and the Department of Social Development, both in terms of working more effectively together in domiciliary care settings, older people living in their own homes, and also in residential care facilities. And secondly, I think we need to start looking much more at issues like health promotion, and also training and increasing awareness of primary healthcare staff about issues like dementia, and simple interventions that can make a massive difference to the health, well-being, and care of older people, such as ensuring they're drinking enough, that they're able to maintain hygiene. And this is a particular area I'm starting to work on, again, with colleagues in South Africa with some funding from NIHR. And as we start to do that work, we noted that in South Africa, in Agincourt, again in Bushbuckridge, as Armando said, pensions can be very, very important in terms of affecting the living arrangements and living standards of very poor households. But where you have limited access to a water supply in a household, limited access to a toilet, and you've got an older person who can't get out of bed or has tremendous difficulty moving around inside the house or is highly cognitively impaired, it doesn't take a lot of imagination to understand that that represents a very serious risk to the health, well-being, and survival of that older person. So, sorry, that's a bit of a scurry through lots of different things, but hopefully it was relatively coherent. And I will share these slides with Adelina at the after the talk, where you can find out a lot more about these various different studies. That's me.
Many thanks for that, and for sharing some of your work and some of your interesting interventions that have been taking place over the last while. Yeah, it's exciting to see. I think, you know, you've raised a range of points that I think there will be quite a bit of debate on from members here. Yeah, we have also posted one or two of the reports that we've been working on over the last year, so they can complement what Peter's been saying in different ways. Yeah, so any questions, please raise your hand. We've got, thanks for that, Peter. I mean, the one thing I'll start off. So, I mean, the one thing I was very intrigued by is your comment that in the Seychelles, it's the only, what you refer to as a home care program. Now, I know you're well aware of the grant in aid in South Africa. That is a cash grant. You know, you've referred to it as tokenistic in your writing. You know, our investigations shown that there's a, you know, very little awareness of it. Those that apply for it generally get it because I think it's a social grant. It's social, for those of you who don't know, to cover for people who have full-time care needs and to cover their care costs. Now, whatever way you want to use that, it is targeted at the older person. So it's not targeted at the caregiver, but it's intended for caregiving costs. And so, Peter, I would, just as a brief question, I would be curious to know how you see the Seychelles program, you know, as uniquely different to a grant in aid.
I'm very happy to do that. And what I can do is I just did a report comparing different programs in Asia, Africa, and Latin America, and that was one of the case studies. So what I'll do, it hasn't been published yet, but I'll share that with the group as a whole. my critical argument is basically boils down to demand versus supply side here. That cash transfers, social insurance, all of these things can help people manage the cost of using services. And that's very important. But those services have to be available in the first place in a way which is appropriate and affordable. And the argument I'm making is that cash transfers, any kind of cash transfer or demand side intervention, which deals with costs of services, can't deal with the other side of the equation. So in the case of care grants of different kinds, if you don't have an infrastructure in place which supports family carers, if they're the ones who are going to spend the money on their own needs, increasing what I would call their care literacy, their awareness of hydration, hygiene, dementia, and how to handle it. If you don't have good primary healthcare services in place which have some awareness of these issues and that intersection of health and care, I think you're missing a huge trick, you know. And my concern is that I think there is a very powerful discourse out there at the moment among large global agencies that they think we've got this big new problem, so, you know, care dependency, older people, and that's okay because cash transfers can do all kinds of different things. They're relatively easy to implement as a policy, trying to, you know, ignore the issues of targeting, which I think are quite difficult. They're relatively easy to implement, and that will be job done. And that is my concern. There is such a strong discourse out there that I feel sometimes it's important for me to be a bit of a controversialist, although I think the controversies that I put forward are evidence-based.
Thanks, Peter. I don't necessarily disagree with the logic, but some of the content of, you know, it can be argued also differently. I see two hands. I'm going to hand over to Isaac and Penny.
Yes.
Welcome, Isaac and Penny.
There's also one in the chat, question
okay.
from Christy Adams.
Perhaps what we'll do is we'll take the three questions, allow for time to respond, and that may be the only time we have. So Isaac and Penny, if you don't mind, to keep it a little bit short. Thanks. Go ahead, Isaac. Rest.
Okay, thank you. My question is, thank you for the good presentations, and I have only one question in the interest of time. In your presentation, Amanda and Peter, have you tried to think about the relationship between political will and physical space and extension of social pension or introduction of social pension to other people, and how that affects care? Because here in Zambia, I've been doing a lot of work on other people, social protection. What some of the issues have revolved around the issues of political will and physical space. Government is always talking about physical space, and because of that, they give the excuse that they are not able to introduce social pension, and because it's too expensive, and that actually affects care for the other people. Thank you.
Thanks, Isaac. Penny?
I was just going to say that there's a real tension between the fact that we think families should be looking after older people, and the older people have money that is separate and only for them. And while Peter's absolutely right to look at how households spend money on food, there's education and a whole bunch of other things, marriages and so on. And my experience is that actually older people, particularly women, older women, see themselves as pushing everything towards the youngest generation because their lives are over and their lives are yet to come. And so I think we have to look at it in the round. And if the government is providing pensions at a point that's convenient for them once a month, at a place that's convenient for them, or in India once in 6 months, that's a huge sum of money for the family as a whole. So that's a real tension there between administrative ease and what the dynamics within families. And absolutely clearly what Peter's saying about, you know, if the pensions aren't enough, if there aren't other resources all around, you cannot support older people alone. It's got to be seen within the context of the kinship, wider kinship.
Thanks, Penny. I see the question in the chat, Peter and Armando, is from your research, what could have been the factor for the high blood pressure in South Africa in the history of human race? From Christy Adams to everyone. Okay, I'm going to hand it back over to you. We literally have 1 minute to respond, so please keep it short.
I will defer to Armando on Isaac's question. The hypertension question, it's basically, you can answer that in a number of ways. On one level, it's all the risk factors that you have for hypertension. obesity, smoking, diet, etc., alcohol consumption. But below that, of course, you have to say, well, what are the deeper reasons, the more structural reasons why you have high obesity, high rates of tobacco and alcohol consumption in South Africa? And that's where you look at the social determinants. And that's an answer I can't give in a minute.
And I'm just going to make a point that perhaps I should have made earlier, but the way I see old age grants in South Africa and non-contributory pensions or social pensions in other countries is not really income for old people. There is income to a household that is run through an older person, where the older person is the recipient, but it's really a household transfer. In South Africa, there's been the long discussion about the people in the Middle Ages. You have a grant for children, a grant for older people. What about the people in the middle? And I really don't see that in real terms working. As I said, social pensions are really a household transfer that is given by older people. Now, the question why, I'll be very, very quick. The question why is done through older people, partly because it's more, it facilitates political support from parliamentarians, partly because it signals that governments are committed to the long run, as opposed to kind of clientelistic short-term transfers. A pension is really for the long run, and also for political electoral support reasons, in that older people are register and vote, whereas younger people don't. I'll stop there. Thank you.
Thanks, Amanda. Thanks, everybody. I know we've run out of time, and I know there's a lot of interest in this topic. We do have 3 more seminars coming up within this interest group. The next one will be held on the 31st of May, and it will be on pensions and why they vary. So we'll continue this conversation really in more depth from 3 speakers. Professor Natsani in Botswana, who's written extensively on social protection in the region. Professor Jeremy Seekings, who many of you will know has written on social protection also in the region. And Professor Mauricio Natana, who's written also on pensions in Malawi and Ghana. So I look forward to that. We have further 2 sessions later in the year, which we will advertise in time. Thanks very much, everyone, for attending. Thank you, Adelina, for hosting us.
Just to plug that, on the 11th, we'll be looking at dementia stigma, and one of the countries we'll be covering is Kenya, so it may also be of interest to some of you. I've put the link in the chat, but you can go to the goltc.org website. You'll find all the webinars and the recording for this one. And thank you so much for joining. Thanks for the amazing presentations and the great engagement. Thank you all.
Thanks, everybody.